and welcome to part 2 of our case file from a pediatric book about the failure to thrive, and we'll continue from the diagnosis. All body organ systems potentially harbor a cause of organic failure to thrive. And we have a table here for the major causes of inadequate weight gain. First is inadequate caloric intake, which include lack of appetite due to depression or chronic disease. We have ingestion difficulties due to feeding disorders, neurological disorders like cerebral palsy, craniofacial anomalies, genetic syndromes, and tracheoesophageal fistula. Unavailability of food due to neglect, inappropriate food for age, and insufficient volume of food. Altered growth potential, such as parental insult, chromosomal anomalies, and endocrine disorders. Next come caloric wasting by either emesis, malabsorption, or renal losses. Emesis due to intestinal tract disorders, drugs, toxins, or central nervous system pathology. Malabsorption due to gastrointestinal diseases such as biliary atresia and celiac disease. Also other causes of malabsorption, inflammatory bowel disease, infections, and toxins. Causes for renal losses, diabetes, renal tubular acidosis. So renal losses due to diabetes or renal tubular acidosis. Finally, of the major causes of inadequate weight gain, there is increased caloric requirements, either by increased metabolism due to congenital heart disease, chronic respiratory disease, neoplasms, chronic infection, or hyperthyroidism, and increased caloric requirements by defective use of calories due to renal tubular acidosis. So that was the table for major causes of inadequate weight gain. The developmental status possibly delayed in organic and non-organic failure to thrive needs evaluation. Children with non-organic failure to thrive may demonstrate an occipital bald spot from lying in a bed and failure to attain appropriate developmental milestones resulting from lack of parental stimulation, may be disinterested in their environment, may avoid eye contact, smiling, or vocalization, and may not respond well to maternal attempts of comforting. Children with some types of organic failure to thrive, for example, renal tubular acidosis, and most non-organic failure to thrive, so children with some types of organic failure to thrive and most non-organic failure to thrive show catch-up in developmental milestones with successful therapy. So they start to improve. During the examination, especially of younger infants, the clinician can observe a feeding which may give clues to maternal-child interaction, bonding issues, or to physical problems, such as cerebral palsy, oral motor or swallowing difficulties, velium cleft palate. The history or examination suggestive of organic failure to thrive directs the laboratory and radiologic evaluation. In most cases, results of the newborn state screen are critical. A child with cystic fibrosis in the family requires sweat chloride or genetic testing. A child with a loud, harsh systolic murmur and bounding pulses deserves a chest radiograph, an electrocardiogram, and perhaps an echocardiogram and cardiology consult. Most failure to thrive children have few or no signs. Thus, a laboratory evaluation is usually limited to a few screening tests. A complete blood count, CBC, lead level, especially for patients in lower socioeconomic classes or in cities with high lead prevalence. Also, we need urinalysis and culture and serum electrolyte levels, including calcium, blood urea nitrogen, and creatinine. So, laboratory evaluation is usually limited to a few screening tests such as CBC, lead level, urinalysis and culture, serum electrolyte levels, including calcium, blood urea nitrogen, BUN, and creatinine. A tuberculosis skin test and human immunodeficiency virus testing may also be indicated. Abnormalities in screening tests are pursued more extensively. Treatment and follow-up. The treatment and follow-up for organic failure to thrive is disease specific. Patients with non-organic failure to thrive are managed with improved dietary intake, close follow-up, and attention to psychosocial issues. Healthy infants in the first year of life require approximately 120 kilocalories per kilogram per day of nutrition and about 100 kilocalorie per kilogram per day thereafter. Failure to thrive children require an additional 50% to 100% to ensure adequate catch-up growth. A mealtime routine is important. Families should eat together in a non-distracting environment with the television off. With meals lasting between 20 and 30 minutes, solid foods are offered before liquids. Children are not force-fed. Low-caloric drinks, juices, and water are limited. Age-appropriate high-calorie food like whole milk, cheese, dried fruits, and peanut butter are encouraged. Formulas containing more than the standard 20 calories per ounce may be necessary for smaller children, and high-calorie supplementation may be required for larger children. Frequent office or home health visits are indicated to ensure weight gain. In some instances, hospitalization of a failure to thrive child is required. Such infants often have rapid weight gain, supporting the diagnosis of non-organic failure to thrive. Non-organic failure to thrive treatment requires not only the provision of increased calories, but also attention to contributing psychosocial issues. Referral to community services may be required. Community services such as Women, Infants, and Children Program, Food Stamp Program. Referral to community services may be required. Caregiver help in the form of job training. Caregiver help in the form of job training, substance and physical abuse prevention, parenting classes, and psychotherapy may be available through community programs. Older children and their families may benefit from early childhood intervention and Head Start program. Some children with organic failure to thrive also have non-organic failure to thrive. For instance, a poorly growing special needs premature infant is at increased risk for superimposed non-organic failure to thrive because of psychosocial issues, such as poor bonding with the family during a prolonged hospital stay. In such cases, care for the organic causes is coordinated with attempts to preclude non-organic failure to thrive. Finally, the clinical pearls of this case: inexpensive laboratory screening tests, dietary counseling, and close observation of weight changes are appropriate first steps for most healthy appearing infants with failure to thrive. Organic failure to thrive can be associated with abnormalities of any organ system. Clues in history, examination, or screening laboratory tests help identify affected organ systems. Up to 1/3 of patients with psychosocial failure to thrive have developmental delay as well as social and emotional problems. Patients with renal tubular acidosis, a common cause of organic failure to thrive, can have proximal tubule defects type 2 caused by impaired tubular bicarbonate reabsorption, or distal tubule defects type 1 caused by impaired hydrogen ion secretion. Type 4 is also a distal tubule problem associated with impaired ammoniogenesis. And that is all. Shukriya everyone for listening, and inshallah we'll see you in the next case from a different book in another time. Don't forget to like, subscribe,
and to comment.